pressures would go down, so would all your other values, frequency of breathing faster. All of this indicate there's an obstruction there. If it was restrictive, then your FEV 1.0 over FVC, the percentage there, which was very low, it was 56 when normal is 75. The FEV, or the expiratory volume in a minute, would not be that low. It would be normal or slightly lower, but not that much. So it's most probably obstructive and not restrictive. Obstructive would mean it would block your airways. There would be more resistance for air to enter. So all those values would change. Number 3 says, write the formula for determining residual volume, RV. I'm putting the formula up in here as well while I speak. RV, or residual volume, is equal to your total lung capacity, TLC, minus vital capacity, or VC. And usually normal people, male, female, the residual volume is 1.2 liters. This is the amount of air left in lungs after you after an expiration. Number 4 says, determine the residual volume, or RV, before and after the use of the bronchodilator. Now, before using the bronchodilator, the way you calculate RV would be to take your two values, total lung capacity and your vital capacity, straight from your data page there in your case study. So our RV, first RV before the bronchodilator, was 3.92 liter. We get that from deducting 2.9 from 6.82. And our second one, the RV after bronchodilator, is 1.81 liter, and we get that by deducting 4.15 from 5.96. Now you can see the residual volume has dramatically decreased after the treatment from 3.92 to 1.81. Remember, normal is 1.2, so it's very close to normal. Number 5 says, why is expiration more difficult than inspiration in this person? This is a really good question. Now, if you have to think about your expiration and inspiration here. Remember, your expiration is a passive process, which means that whenever you're expiring, what you're doing is you're using your bronchiole is actually kind of closing a little bit. That's how you squeeze this, getting the air out when you're breathing out. When you're inspiring, when you're getting this air in, remember the pressure change. Air is always going down the gradient, right? High to low. So when that happens, you have inspiration causes your bronchioles to expand, to maximally just expand more, so you have a lot of volume and air can come in, which is why you don't have much of a problem in inspiration, because your air passage is expanding, it's dilating, so you have air coming in. But when you're expiring, when you're getting the air out, as it is, your bronchiole with asthma, it's already blocked with all the mucus, the cough and everything. So you already have a narrowing of the bronchiole, and now that you're trying to breathe out and it's trying to narrow it more, you have even little less space for expiration, which is why in this case for number 5, expiration is more difficult than inspiration. So number 6 says, what does the change in pulmonary function after the bronchodilator therapy indicate? Well, the therapy, broncho, again means your bronchus, dilator dilates it. So since asthma causes your bronchus to constrict, using the dilator, you're just dilating it, so you're relieving your bronchus, and that's what it's indicating. Your bronchoconstriction is relieved by your bronchodilator. Number 7 says, why does the bronchodilator exaggerate the tachycardia? Remember, the bronchodilator they used there was epinephrine. And if you can remember, epinephrine is one of those neurotransmitters released in, remember, postganglionic neurons are releasing epinephrine in your sympathetic division. Parasympathetic is only using acetylcholine. Never forget that, right? So now here, when you are using epinephrine, you're going through your sympathetic division. Sympathetic division has an effect on your bronchus, which you looked at, which is good. It has dilated it. But sympathetic also has an effect on your heart. Remember, sympathetic division causes your heartbeat to go faster. Adrenaline, one of those effects, when you get scared, heartbeat goes faster, blood pressure goes high. So there you go. Epinephrine causes sympathetic division stimulation, which causes your heart rate to increase, which is why one of the things is tachycardia, fast heart rate, which is why your pulse was higher and so was your blood pressure in this case. Number 8, what causes the hypoxemia and hypocapnemia in this person? Hypoxemia is whenever you have low oxygen, and hypocapnemia is whenever you have low carbon dioxide. The cause of hypoxemia is bronchoconstriction. When your bronchioles are constricted, you're trying to breathe in air, and it is the constriction is not causing maximum air in, even though you have in inspiration, even though your bronchus are expanding, still the mucus is causing some less oxygen to come in. So that's what's causing your hypoxemia. Another thing is, remember, in your alveoli you have gas exchange happening, and now that the alveoli has all this mucus in your asthma, right, the cough there accumulates, it's hard for gas exchange to happen across your alveoli, the wall, to go to your capillary because of this distance. The mucus is causing a big distance for oxygen to cross. So same case with carbon dioxide as well. But that distance increase causes a problem in diffusion, which increases your residual volume. That's why you have some left over in there. So that's causing your hypoxemia. And hypocapnemia is caused also, low oxygen is caused mainly because of that too. And one of the things you see in here is the frequency of breathing, which increases. The fast breathing, we call it. You have 20 breaths per minute when you measured that. That was because you're trying to get rid of your carbon dioxide, from there, because you're not getting most of it out from your system because of the constriction in there. Another thing is the diffusion of carbon dioxide, if you compare it with oxygen, is actually 20 times more. Remember, carbon dioxide is more soluble in blood, so a diffusion of that is 20 times more. So releasing from the, when you're thinking of releasing from the lungs to the blood, that is going faster. You have no problem over there. So the problem is when you are releasing your carbon dioxide from your lungs outside to the air. Okay, that was number 8. Number 9 says a beta-2 adrenergic agent was prescribed for further use because it has less cardiostimulatory effect. Based on your knowledge of beta-1 and beta-2 receptors, why is this a good suggestion? Remember your beta-2 receptors. Most of your beta-2 receptors are actually in your bronchioles, but on the other hand, your heart muscles has beta-1 receptors, some beta-2 too, but most of your heart muscles and your heart SA node, for example, all of that has a lot of beta-1 receptors. So that's why it is kind of a good idea to give something that is specific to beta-2 receptors. In that way, you don't affect the heart. Remember, in her case, giving epinephrine, which epinephrine goes both way, beta-1 and beta-2 receptors. That's why she had parasympathetic and sympathetic division being affected. But if they gave her a drug that would only affect your beta 2 receptors, that